Hello everyone, welcome to today's live broadcast, Syphilis Diagnosis, Treponema Algorithms from the Public Health Perspective. This is an especially relevant topic given the recent release of updated Centers for Disease Control and Prevention Sexually Transmitted Disease Guidelines just a few weeks ago. My name is Dr. Tiffany McKenzie, and I am the Scientific Affairs Manager of Infectious Disease, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by Soren, the diagnostic specialist and global leader in vitro diagnostics worldwide. You can find more information about Soren at www.diasorin.com. Now we have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to submit questions throughout the presentation. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button in the lower left-hand corner of your presentation window. We'll try to answer as many of your questions as we can. And at any time, you can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the presentation window. And if you have any technical difficulty hearing or viewing this presentation, please click the support button in the top right of your presentation window, or submit your problem through the green Q&A button in the lower left, which I just mentioned. I would now like to introduce today's speaker, Dr. Richard Steece, who currently serves as the Certified Public Health Laboratory Director for the State of Tennessee Department of Health. Dr. Steece comes into this role with over 30 years of experience and is one of the nation's leading public health laboratory experts. Among his multiple admirable roles driving public health initiatives in the U.S., Dr. Steece has recently served as the National Chlamydia Laboratory Coordinator for the CDC, as Science Advisor to the Association of Public Health Laboratories, APHL, and most recently, Dr. Steece is the incoming chair of the 2015 STD Subcommittee for APHL. Dr. Steece has worked with every city, county, and state public health laboratory in the nation, and it is our great pleasure to have him here with us today. And now I turn it over to Dr. Steece for his presentation.
Well, thank you, Tiffany, for that nice introduction. And before we get started today, I'd actually like to thank Soren for sponsoring the presentation today and making it possible for me to spend some time with all of you. The title of the presentation today is Syphilis Diagnosis, Treponemal Algorithms from the Public Health Laboratory Perspective. And if you can see in the first slide, there we go, the first slide, the list of objectives, we're going to be talking about more than just algorithms. We really need to talk about the signs and the clinical disease, the specific tests and how they perform before we can even talk about algorithms. So what we're going to try and do today, we're going to discuss the epidemiology of syphilis, the signs, the symptoms, the clinical disease, and treatment, so that we can better understand syphilis screening. And then we're going to discuss the laboratory tests that are available for syphilis, their advantages and their disadvantages. We're also going to talk about the laboratory guidelines, or perhaps lack of guidelines, or at least the recommendations that are currently available for syphilis screening, and the necessity to perform at least 2 independent laboratory syphilis tests to confirm the diagnosis of syphilis. And then we're going to be talking about the different syphilis testing algorithms and how those might apply to your laboratory. In this slide, we can see that there's at least 3 other subspecies of Treponema pallidum or Treponema pallidum that are known. They're rarely transmitted sexually or congenitally. They're responsible for cutaneous or bone diseases and are endemic to certain regions of the world. Bajal, which is endemic in the Middle East and North Africa. Yaw is endemic in Africa, Asia, and South America. And Pinta, that's endemic in Latin America. And well, why is it important that we know that there's subspecies of Treponema pallidum? Well, these subspecies actually do cross-react with the specific treponemal tests. We always think so much about the non-treponemal tests having specificity issues somewhat, but the treponemal tests also have some issues occasionally with cross-reactions. And as we know today, Anybody that's in the U.S. can be in any country in just a matter of a day or hours, and somebody that's in another country can be in the U.S. So we may see individuals that have lived in those countries or visited those countries or had extended stays here in the U.S., and it's helpful to know some of the things that potentially could cause false positives in our treponema assays. There's other things that might potentially cause false positives, and we'll talk about them a little bit later in the presentation. Things like periodontal disease, because we all know the microflora in our mouth contain a lot of spirochetes, and some of those can cross-react too, even in some of the most specific tests that we have for syphilis. So it's just something to keep in mind when we go through talking about the diagnostic tests and the specific tests. Syphilis, or treponema pallidum, we'll just call it treponema pallidum for short. Usually we don't use the genus and subspecies, and it's a spirochete, as we all know. And because it's a spirochete, we know that it doesn't stain with the usual bacteriology stains. It's sexually transmitted, as we all know, and transmitted transplacentally to the newborn. Untreated syphilis is marked by 3 clinical stages: the primary, secondary, and tertiary stages that we've heard so much about. Spirochetes appear in the lesions and in blood during the first 2 stages, or the communicable stages of syphilis. Syphilis is susceptible to various chemical and physical agents. It's a pretty wimpy microorganisms as microorganisms go. It's extremely fastidious and sensitive to heat, cold, drying, disinfectants, soap, high oxygen tension, and pH changes. It only survives minutes to a matter of a few hours in body secretions, and it survives up to 36 hours in stored blood. If we look at the side from the CDC, we can kind of look at syphilis and get a little bit of a history of syphilis and the reported cases by stage of infection. The total number of syphilis cases you can see on the far left part of this slide have gone down significantly from the 40s and 50s. Well, part of that was the advent of penicillin, certainly, and it was also the advent of extremely aggressive public health programs. There were hundreds of actually public health officials, disease intervention specialists, people actually wearing out their shoe leather, running down and doing contact tracing. So there was a very aggressive program during these years with many individuals involved to start bringing these numbers down, and along with very good treatment. And we see the numbers continue to go down until about the early 90s. We see a little blip, and then the cases started going down again. But when we look at about 2001, we see the cases starting to go up a bit. So the total number of cases increased 13.1% in 2012 and 2013. Now, real good news. In the next slide, if we look at the primary and secondary cases of syphilis, the reported cases by stage, sex, and sexual behavior, we see that MSMs account for a majority of the cases. They actually account for 75% of the cases in 2013. Men who have sex with women, or MSW, the cases have actually increased. If we look at the previous surveillance reports, the numbers have actually gone up a little bit. Women, well, we'll see in a minute, that remain pretty much the same. We look at the next slide, we can see the male to female rate ratio has gone up. The male rate has continued to go up. The total rate is going up. The female rate has remained fairly stable over the last 10 years or so. That's kind of the good news and the bad news. The good news, it hasn't gone up significantly, but the bad news is it hasn't gone down. And when you look at untreated early syphilis in pregnant women, it can result in perinatal death up to 40% of the cases. So it is significant that we still have syphilis around, and it's something that we really need to pay close attention to from the public health perspective. All right, let's look a little bit at the symptoms of syphilis. Those will help us understand the specific assays here that we'll get to in a few minutes. Primary syphilis is usually marked by the classic chancre or the painless open sore that we see from 10 days to 3 months, usually in the period of 2 to 6 weeks. The chancre is ordinarily painless, sometimes internal, and oftentimes will go unnoticed. It's usually found on the part of the body exposed to the bacteria. For example, the penis, the vulva, the vagina, but the chancre can also develop on the cervix, the tongue, lips, or fingertips. as you can see in the lower right-hand part of this slide. And it self-resolves or disappears within a few weeks on its own. In secondary syphilis, we see the characteristic skin rash, somewhere in the range of 2 to 12 weeks after the disappearance of the initial chancre. When the chancre dries up, goes away, skin rash is the next thing that comes along in secondary syphilis. This rash may cover the entire body, or it may just appear in a few areas, such as the palms of the hands or soles of the feet, and not be widely recognized. In secondary syphilis, you might also see that rash accompanied by flu-like symptoms, such as mild fever, fatigue, headache, sore throat, as well as patchy hair loss, swollen lymph glands throughout the body, and other problems. If you remember, quite a few years ago, we used to call syphilis the great mimicker. It can mimic a lot of different infectious diseases. The secondary rash of syphilis usually heals within weeks to months, and the other symptoms gradually do subside. However, these signs and symptoms may occasionally come and go over the next 1 to 2 years. Then it moves on to tertiary syphilis, where we see the major damage either starting to or has already occurred to the heart and to the eyes, the brain, the nervous system, the bones, the joints, or almost any part of the body. This stage can last for years, up to the lifetime of an individual, leading to the final stages of mental illness, blindness, heart disease, and even death. Now, keep in mind that we're talking untreated syphilis, looking at these primary, secondary, and tertiary stages of syphilis. Congenital syphilis, we see a variety of different symptoms. We may see a nasal discharge, skin eruptions, bone deformation, seizures, nervous system abnormalities, premature births, stillbirths, and even death. I put this slide in. This really gives a nice kind of a graphic presentation of what we've just been talking about the infection, the initial infection, the incubation period, roughly the times, and the stages. So keep this slide in mind. It's a little easier to look back at this slide in your mind or in the presentation when we start talking about some of the non-treponemal, treponemal tests, and when we say that one of the tests is more sensitive during the primary stage or more specific during the late and tertiary stage. I think this guide will really help us. So keep this in mind as we start talking about some of the specific tests for syphilis. Uncomplicated treatment of syphilis, benzathine penicillin G, 2.4 million units IM intramuscularly in a single dose. Infants and children, also benzathine penicillin. Not anything new, the same recommendations basically from the last guidelines. However, we're just going to talk about uncomplicated treatment, basic treatment here. If you want more information about treatment during pregnancy, treatment of individuals that are allergic to penicillin, what to do, the new laboratory guidelines from CDC were just published June 5th. So the sexually transmitted disease guidelines for 2015 are out and available. You can go to the URL on this slide. You can download these. You can go on the website and look up anything you want to look up at any time. You can actually order nice hard copies, and they have wall charts that you can get and other resources. So I encourage you to go onto the CDC website because it has a lot of good information about syphilis treatment as well as treatment for the rest of the STDs. Okay, let's move on to syphilis laboratory methods and diagnosis. Looking at the direct tests, we don't see too many of these direct tests around anymore. Those of you who've been around for a few years probably know that we used to do a lot of dark field tests. A light microscope dark field condenser. Used to take a chancre, take a scraping, put on a slide, and do a dark field. If we got a positive dark field, that was diagnostic for syphilis, and we would treat the individuals. Very useful test. However, it's a little bit difficult. You have to maintain some expertise to do dark fields. They're not the easiest thing in the world to do. And if you're doing like one a month, you're not doing enough. And so when the syphilis numbers started dropping, and in some areas of the country, we really didn't have syphilis, or certainly a lot of syphilis anymore, dark field eventually started going away because it was very difficult to maintain that expertise. So it's very difficult to find a site that's even performing dark fields anymore. The direct fluorescent antibody assay came along kind of at the tail end of the dark field. It's a good assay. It was more sensitive than the dark field, but it required an FA scope. And of course, there's an expense involved in that and some expertise just keeping the scope aligned, let alone in doing the procedures. So both techniques, very difficult to find any sites that are even doing those nowadays. The nucleic acid amplified tests, or PCRs, there's currently no FDA-cleared test available. I've talked to several manufacturers, and a lot of individuals on the SCD committee and other individuals have talked with diagnostic manufacturers to try and encourage someone to come out with a good molecular assay, or PCR. And it would be very helpful, very useful to the clinicians to try and differentiate some of the chancres or potential chancres, or is it really a chancre when somebody comes in with a sore? Is that a chancre? Is it a bed sore? Is it a bug bite? Is it an atypical herpes lesion? What is it? So the test would be very useful actually in the clinical field to have available. It can also be very useful with, in the case of neurosyphilis, looking at CSFs, and in congenital syphilis. So it would be a very powerful test to have available, and certainly would be utilized quite a bit. And it's more sensitive than the dark field and the DFA. Serological diagnosis, there's two separate categories, as we know, of tests for syphilis, the non-treponemal category, that are primarily, or were primarily used as screening tests, and are still used and useful for monitoring the efficacy of treatment. We know that in RPR, for example, over time, if we monitor that and individuals being treated, that those titers are expected to fall somewhere between 6 months to a year, and usually completely disappear with successful treatment. Treponemal tests are generally more sensitive and specific than the non-treponemal tests, and they increase your positive predictive value of your reactives or positive non-treponemal screens. And as everyone knows, when you're reactive with a treponemal assay, you're generally reactive for life. There's a few exceptions, but generally you're reactive for life. Okay, we've got a couple tables now to take a look at, and I think this is important to know some of the limitations of these assays. And this table is just a guide. It certainly didn't include every one of the VDRL versions or RPR card tests under the sun, but it's representative of those groups. And we can see when we talked about primary syphilis, if you look back in your mind or look back in the slide set if you have those, at the primary and secondary syphilis, the flow of the clinical symptoms and the disease. This will help you kind of place what we're talking about here. So in primary syphilis, the non-treponemal tests are not bad tests, but they're not as sensitive as you'll see in a few minutes as treponemal tests. So you can kind of get a range of those. And you get a range because there's a lot of different manufacturers and a lot of different ways these studies were designed and set up. But when you do a meta-analysis and you look at it, they do have a lack of sensitivity in the primary stage, where you can see in the secondary stage, most of your non-treponemal tests do very well. And in your latent stage, they do fairly well. But very late syphilis, they may be some issues or some problems. And specificity, while they all look like they're in the high 90s, if you remember back, even at a 98% specificity, if you're screening in a low prevalence population, you're going to have more false positives. So it's something to keep in mind. The treponemal assays, if we again look at primary syphilis, and from the previous slide, you can see that they're more sensitive in the primary stage. Now, this table was put together a little while ago, and we didn't have many EIAs at that time when it was put together, and the CLIA isn't even included, but it appears that the EIAs and the CLIA tests are more sensitive than the other treponemal tests that we have currently available in primary syphilis. So we'll talk a little bit more about that when we start talking about specific treponemal tests. But they certainly are more sensitive in the secondary and for latent syphilis and for late syphilis. If you remember right, in late syphilis, the RPR had some difficulties with sensitivity. And they're very specific assays in addition to their sensitivity. Now let's look at some of the specific tests, non-treponemal tests. The RPR tests I think one of the first companies that came out with an RPR test, I believe, was probably BD, an excellent RPR test, still a good test. There's other manufacturers that make RPR tests. They're all good tests. The ones that are certainly in the U.S., they've all been FDA cleared. The VDRL test, basically the first test for screening, microscopic test versus the RPR test was read macroscopically with your eye. But the VDRL is still used for spinal fluids, and that's one of the main reasons that we keep the VDRL around. The trust assay, again, just a little modification of the RPR. Instead of charcoal particles that are caught in the antibody complex and cause a flocculation, and you can actually see the charcoal particles. They use a toluene red dye that actually is captured. So again, it's a nice little test, just kind of a different version of RPR. And point-of-care tests. I debated whether I wanted to even talk about point-of-care tests, but I mentioned it for two reasons. One, we have now non-treponemal point-of-care tests that are FDA cleared in the U.S. There are non-treponemal tests that are used throughout the world. And we do have one manufacturer in the U.S. that's working on a point-of-care test that has a non-treponemal and a treponemal band in it. And hopefully one of these days we'll see that product submitted to FDA, and we may see it available on the market. But at this point in time, no non-treponemal point-of-care tests available in the U.S. Treponemal tests, our old friend, the FTA, the TPPA, good assays, the enzyme immunoassays, and there's a variety of different enzyme immunoassays. The chemoluminescent immunoassay, the liaison, you can see the instrument on the lower right-hand side of the slide. Point-of-care tests, we do have one point-of-care test, one treponemal point-of-care test that's FDA cleared in the U.S., and that's marketed by Trinity this time. It's actually a product that's made in France, and it's a waved assay. So that is currently available, and we'll talk a little bit about that later. And then, of course, the BioRed microB immunoassay, the MBIA. Just to kind of refresh our memory a little bit about the RPR, we'll get specimens in, and this will be important when we talk about algorithms, but we'll get, let's say, 10 individuals. We have 10 bloods that we spin down, the serums that we take, and we'll put 10 individual serums on this slide, one in each spot. So we have 10 people we're testing here. We'll add our antigen, the charcoal with the beef heart extract, because basically what we're looking for is anti-cardiolipid antibodies. The RPR test does not measure specific antibodies to the treponeme. The treponemal assays measure specific antibodies. The RPR test does not. So that's one of the issues with the specificity problems. So if we get a reactive, and you can see on the slide here, the slides are really difficult to look at, and there is some subjectivity to reading them. The CART test, obviously, you need to read it under incandescent light source, not a fluorescent source, but a nice incandescent bulb. And you kind of rotate it back and forth. Those of you who read these know exactly what I'm talking about. And you look for that flocculation, that clumping, that agglutination look, if you will, of the charcoal particles, the trapped charcoal particles. And specimen number 7 looks, in the slide, looks reactive. A couple of them do look reactive here too. They're kind of fuzzy. It's kind of hard to tell. But what we'll do is when we get a reactive one, like let's say number 7, and then we'll take and go to the RPR quantitative. And you see an example of the quantitative assay right below that. We'll take that specimen and we'll dilute it out. We'll dilute it 1 to 2, 4, 8, 16, all the way out to 512. And we'll look for an endpoint. And you can see from this slide, well, in this slide again, it's not like reading it right into the light, but in the slide looks like the endpoint might be somewhere around 32, possibly over to 64, but it shows up much better when you're actually looking at it than it does certainly being projected here. But let's say it's 1 to 32. That's where the last well you see a positive. So your last positive was at a dilution of 1 to 32, so your titer is 32. Remember that the titer is just reciprocal of the dilution. So when you get a result back that says R32, that means that was reactive or positive out to a dilution of 1 to 32. And we utilize this test to monitor the efficacy of the treatment that I just mentioned before. Okay. Next, the slide is the TPPA assay. Again, a nice little assay. It uses little gelatin particles that are coated with the antigen. We have the patient's specimen, and if we have antibodies, we get nice agglutination, and you can see the unsensitized particles for controls and the sensitized particles with the antigen, the patient's serum, and the agglutination. It's a fairly simple little assay, and it works fairly well. Again, it's read visually, so there certainly is some subjectivity to reading that. The next one is our old friend again, the FTA, been around for a long time. Very good assay. We have the treponemes on a slide. We put the patient's serum on. If there's antibodies, they'll attach to the treponeme. Again, specific antibodies, measuring specific treponemal antibodies with your treponemal assays. And we put our anti-human conjugate, conjugated with fluorescein, and we'll see nice, bright, glowing treponemes in the case of individuals that have antibodies to syphilis. Nice positive FTA. Okay, the non-treponemal assays. Let's take a look at the advantages and disadvantages of those. The advantages are they're fairly sensitive through most of the areas of syphilis, except for, as you can see over in the disadvantage, lower sensitivity in primary infection. Okay? This is important to keep in mind when we start talking about algorithms. Okay? So high sensitivity except in that primary infection. They're fairly rapid, low cost, doesn't detect past infections, requires little equipment for testing, a couple rotators, covers, some pipetters, saline. Not much is really needed to run RPRs. As a matter of fact, the RPR originally was developed as a field assay. A very little card that individuals actually were running out in the field, and they would just use their hands instead of a rotator to rotate it around so that they could treat patients right on the spot. It usually requires only one reflex test. As we know, you do an RPR, you go on to a treponemal assay, and usually that gives you some kind of an answer to take some kind of an action. And it's useful for treatment monitoring. Again, we want to look for that antibody titer to be going down with treatment. So the disadvantages, well, because it doesn't measure specific antibodies, it has some false positives. There are other things that can cause false positives with non-treponemal assays. And lower sensitivity during primary infection that we talked about. It's somewhat labor intensive. You've got a lot of cards, you've got a lot of pipetting to do. And subjective results. You can see, you're looking at these, you're reading these, and sometimes the results aren't real clear. And there's other things that can cause some issues, excess antibody or a prozone effect, and some of the things that can cause problems that we know of if we're working with syphilis, and those of you that have done RPRs. So there are some issues and some problems. Manual data manipulations. If you've got specimens on a form, you're transferring those from a worksheet over to a card, from a card to your computer, there's a lot of manipulations, and there certainly could be potential for error in your translations. Your treponemal screening. Well, the advantage is it's very sensitive and it's very specific. There's subjective results. In the case of the EIAs and CLIAs, as you can see, the FTA and the TPPA are not objective at all. They're subjective. You have to read those by eyeball. But the newer assays, very objective results read by an instrument, automation, high throughput. You can interface these with laboratory information systems. They can also be used as a confirmatory test, as can all treponemal tests, and they can be used as a large volume screening assay using the reverse algorithm, or an alternate algorithm, if you will. And we're going to talk about this reverse algorithm when we get to the further down in the presentation. The disadvantages, they can't distinguish between active and previously treated disease. Again, once you're reactive with the treponemal test, you're generally reactive for life. So if you were screening with just a treponemal assay, that would create a potential for overdiagnosis and overtreatment. And it might require more resources for investigations. Our disease intervention specialists, our DISs, would have to follow up more people if we were screening solely with a treponemal assay. And there may be specific costly instruments tied to some of the newer treponema tests. If you have to buy a new piece of equipment, and well, there's not many pieces of equipment that are cheap these days, so it's probably going to be costly. Those things need to be factored in. Now, some manufacturers, again, reagent rentals, and you add a few pennies to a nickel to a dime to the test, and you have the instruments. So these are things to look at and just things to be aware of when you determine the cost and how and what you're going to use to screen for syphilis. They also might require multiple reflex tests for resolving discrepancies. If we're talking, again, the reverse algorithm, and we'll go into more detail on that in just a few minutes. Okay, so you remember back in the slide, one of the first or second slides shown the CDC slides. Syphilis has really reemerged as a public health threat in around 2001. And those case rates have steadily increased, overall increased since then. Efforts to eliminate syphilis are apparently falling short. The current state of laboratory diagnosis may be a contributing factor. Reaching populations that we should be reaching and aren't certainly could be a factor too. But if we look at the laboratory diagnostics perspective, it may be because we have limited access to direct detection. If we had a good direct detection method, such as a PCR, it might really help the programs to address the situation with these rising syphilis rates. And we have a heavy reliance on the serological-based assays. And as you know, serologies are basically an indirect or an evidence of antibody. So they're kind of an indirect evidence, if you will, of syphilis or prior syphilis infections. They require a normal immune response. Individuals that are immunosuppressed or in individuals that have HIV, the response isn't always the same as it is in normal individuals. And there's non-specific and false negative reactions, and we do know what causes some of those, but we don't have all the answers. So there are some problems with the approaches that we're currently taking to try and reduce syphilis in the U.S. So the need for laboratory guidance. Well, when CDC provides guidelines, they influence both public health laboratory and the clinical laboratory practice. They're very influential. They usually address the appropriate use of these tests, or a variety of tests. You're talking about syphilis in this case, and test performance. The test performance is dependent upon the stage of the syphilis infection. And what about the HIV co-infection? These are things that guidelines could help address. Test interpretation, need for reflex testing, the need for repeat testing, additional specimens. It would be really nice to have some national guidance to provide answers to some of these questions that come up in the laboratories. Well, CDC did take an attempt at that in January 2009. There was an expert consultation that was held. It was actually held concurrent with the Committee on Gonorrhea expert consultation just down the hall. And multiple areas at that time were discussed with the syphilis experts. The direct detection of treponema pallidum or syphilis, things like PCR and dark field, etc. Congenital syphilis, use of IgM or other tests to detect congenital syphilis. Neurosyphilis, what tests could we use? What tests could we use to differentiate other entities from syphilis? And serology. Well, that information from that expert consultation is available. It's on the APHL website, and the URL is listed at the bottom. So you can go on and you can find those recommendations that were put on the website about a month after the, or less than a month after the expert consultation. And if you forget the URL or don't have access to that, if you just go on the aphl.org website, you can go under infectious diseases, under STD, and you can go in and find this, as well as other documents that are very useful to individuals that are performing STI or STD testing and screening. We're just going to talk about the syphilis aspects that were discussed at that expert consultation today. Some of the things that were discussed, there was a lot of talk about the enzyme immunoassays, and the enzyme immunoassays, some of them hadn't been around too long. So keep in mind, in 2009, there's been more information that's come along since then. But at that time, it was determined that most of the EIAs performed equally well for screening. Those that detected both IgM and IgG appeared to be a little bit more sensitive in early disease. There was a limited head-to-head comparison data available, especially with the clinical luminescent immunoassays and microsphere, although the data at the time suggested that the CLIA actually was the most sensitive of the treponemal assays that were currently available at that time. There's also variability in the performance of the different treponemal tests, as you know, due to the antigens of the test, the conjugates, the proprietary methods of assembling these tests. So there are a variety of different things, and there was some variability. However, even with that variability, the overall agreement between the treponemal tests was usually greater than 95%, even in primary disease. Now, that's not the complete whole picture, and we're going to talk about that again in a few minutes when we talk about algorithms, or something that sometimes we frequently miss when we're talking about that. Even though they perform fairly well and fairly equal, there are some differences that we'll talk about. Okay, some of the questions that came up were the serological response following successful treatment of syphilis infection was really unclear based on treatment and stage. If somebody's treated very early, what happens serologically? We do know that with successful treatment that the RPR generally goes away, but what happens to the long-term effect of the treponemal test if they're treated very early? Does it disappear? If they're treated later in secondary syphilis, it appears that it doesn't. So there's a lot of unanswered questions about really what happens with these serological assays, and then if individuals are screened in the future, how do we interpret some of that? So there were a lot of questions that were raised. Also, interestingly, most biological false positive reactions with the non-treponemal and treponemal were generally seen in the sera of, quote, healthy individuals, at least individuals that appeared healthy. No external signs of any disease or infectious disease. And at that time, the clinicians felt that the data did not support that pregnant women have a higher rate of biological false positives. And that's really interesting because I remember all the cases of false positive results that we used to get in pregnant women. And when I heard this, it caused the laboratories to kind of start thinking a little bit and looking at this. And while we used to see a lot of these biological false positives, the clinicians, one of the things they would say is, well, I don't know why I sent this specimen in. Anyway, they'd say, well, you know, if you don't want to know the answer, don't send it in to ask the question. And we deal with a lot of individuals that had these RPRs that were most likely false positives. We had some other tests and some other methods that we worked with CDC on at that time that would help determine that. But to be on the safe side, we really didn't have enough information, and the clinician was going to treat. They generally had no choice in treating. You're not going to treat a pregnant woman if you can't get a definitive answer of whether this is a true positive or not. But I think the reason that these stood out is because we had so few of them. They weren't pregnant women. So that's really interesting because that used to be kind of a common misconception among laboratorians that pregnant women have a higher rate of biological false positive. Well, it turns out it's just that we notice those and have to deal with those more often, but that's not really truly the case. And the higher rates in elderly may point to periodontal disease as a cause of biological false positives. And we talked about that earlier, about the spirochetes in the mouth. And that's one of the reasons when we do a dark field, we don't do a dark field from any oral lesions, because there's other spirochetes. So spirochetes from an oral lesion is not necessarily diagnostic for syphilis, versus on the penis it certainly is. So one thing to remember from our dark field days. Okay, if we go on and look at some of the other recommendations that were made, the selections of specific tests for screening depends on the prevalence of the disease in the population. The purpose of the test, whether you're going to use it for screening or confirmation, the subjectivity of the test and the experience of the technologist, the equipment, the costs, etc. These are all things that should go into the consideration when you're looking at syphilis laboratory methods, the ones you're currently using and evaluating, or the ones you're looking at maybe moving into. And more than one algorithm may be necessary. When using the non-treponemal test as the initial screen, which most of us are very familiar with, the so-called traditional screening method, and when using a treponemal test as an initial screen. Even if we're using the treponemal test as an initial screen, we probably started using the non-treponemal test at one point in time, unless we're really new microbiologists. So a combination of treponemal and non-treponemal tests must be used, whether you're using the traditional or the reverse algorithm. A single treponemal test cannot be relied upon for syphilis diagnosis. This was a little algorithm that was put together by Dr. Vicki Pope. Vicki actually worked at CDC. She put this publication out in 2004, and she made some recommendations, talked about the traditional testing algorithm using the non-treponemal test as her initial screen. And you can see the non-treponemal test at the top, the RPR, VDRL trust. And if it was non-reactive in this simplified algorithm, Dr. Pope said, probably not syphilis, or perhaps early syphilis. It did offer a little bit of a further explanation. If it was reactive, of course, we all know that we go to the titer. We titer the specimen out, and then we reflex that to a treponemal test. And historically, traditionally, that's been the FTA and TPPA. Now, those could be EIAs here, CLIAs, perhaps even a point-of-care test, the treponemal test. So a treponemal test for a reflex test. If it's non-reactive, it was suggested in this algorithm that it was a false positive non-treponemal test. Certainly could be true, but if it was non-reactive, you remember that in primary syphilis, there are some issues, and there's issues with false positivities. So if it was reactive, syphilis and treat. Very straightforward, not a lot of detail on it. The alternate, or the reverse algorithm, the testing algorithm using EIAs or CLIAs as the initial screen. If it's reactive, we kind of go reverse, and we do a non-treponemal test. And we'll titer that specimen out, and depending upon the results, if we get a positive, it would be consistent with syphilis. If it's negative, it was suggested that we run a treponemal test that uses a different antigen or platform from a different manufacturer. Okay, now here's the situation. When we have treponemal assays, where they all perform fairly well, fairly good sensitivities on all of those assays, we know that some definitely perform a little bit better than others. And the data that we had at the time, of course, on the CLIA indicated it was a more sensitive test. So if we screen, let's say, with CLIA, you can see the problem coming here. And we got a negative, or positive, or negative, and then we had to do the repeat treponemal test. And we screened with a test that was less sensitive, we're going to get a negative. So you're screening with a test, you're confirming, if you will, a test that's less sensitive than a test you're screening with. So there's some potential problems, and you need to keep these things, and you need to be aware of these things when you're using these screening assays. So there needs to be more guidance, and we're going to talk about that more guidance in just another couple of minutes. One thing to remember, no matter what algorithm you're using, if you're using multiple assays, in this particular case, the laboratory should report the results of all 3 assays. I have to get in our regulatory end. If we do 3 different assays, we're obligated from our regulatory agency to report the results of all those 3 assays too. So that's one thing to remember too. Okay, let's talk a little bit about the traditional algorithm. Well, it detects active infection usually fairly well. There's a high rate of biological false positives. We use the treponemal test as a confirmation test, if you will. That's what we have called it, a confirmation test. The use of both of these tests, if positive, result in a high positive predictive value, but we certainly can miss early primary or treated infections. The reverse algorithm detects early primary and treated infections that might be missed with the traditional screening. The non-treponemal test is still needed to detect that active infection and also monitoring that efficacy of treatment. The EIA and CLIA and other treponemal tests have higher specificity than the non-treponemal test. So very good assays. Okay, so why are laboratories switching to chemoluminescent immunoassays and enzyme immunoassays? Well, the advantage is they're automated. They're really great for high throughput. So if you have staffing issues, it's really nice to be more automated. They're low cost and high volume settings. Of course, most tests, the larger the volume, the more efficient the test is. Objective results, they're read with an instrument, and some of the tests may detect IgG and IgM and potentially more positives in early syphilis, depending on their conjugates. Also, some of the manufacturers are working on, and probably will have, some specific IgM tests available, which might be very useful to differentiate some of the primary cases of syphilis from a past infection. Some of the disadvantages, you can't distinguish currently between these active disease and old disease. Studies comparing the test performance against these others, head-to-head comparisons, we don't have a lot of those. We need more information and more head-to-head comparisons. So it can be confusing sometimes to manage these patients with the discrepant serology. You get a positive EIA, a negative RPA, or RPR. What do you do? What type of recommendations can be made? Well, the Association of Public Health Laboratories, the Infectious Disease Committee, specifically the STD subcommittee, has been working on a variety of educational materials, some training modules for syphilis, as well as some suggested reporting language for syphilis diagnostic testing algorithms. And they have pretty much a final draft of this. The finalized version will be available, as I mentioned, later this summer. And they'll look pretty much like what you see here. This is just the top portion of that. We've got the non-treponemal, or the traditional algorithm at the top. And in that, if you look at step 1A, you'll see the RPR, and in this particular case, it's non-reactive. So a follow-up would not be indicated. Treponemal assay would be not indicated. And what would be the interpretation for the laboratory report? What further actions might you want to take? Now, this sheet, again, it's just the top. This will be a one-page sheet, and it's going to cover the rest. It's going to cover the next step would be reactive or weakly reactive, treponemal reactive, treponemal non-reactive, all the different possible combinations that we might see with traditional testing. There's going to be an interpretation, a suggested interpretation for laboratory reporting, and further action recommendations to provide some guidance to individuals in the field that are using the non-traditional testing methodologies. And in addition, some of the rare situations will be covered that we get an older individual with hearing loss and an audiologist, so want to send that in to see if it might be related to a past syphilis case, where he or she might ask us to do just a treponemal assay. Some of the strange requests that we might occasionally get to support specific requests from clinicians and public health needs. So it'll cover all the standards as well as some of the rare or unusual with these interpretations and further actions. So it'll be a very good document and certainly very timely. We also have the reverse algorithm that you can see on the bottom. And again, it's just the top row because this hasn't been finalized yet, but these non-reactive are pretty straightforward. So the language, we're working on finalizing the language, but it'll be a one-page thing where we'll have the EIAs, the CLIAs, MIAs, and if they're non-reactive, the next quantitative RPR would be non-indicated, treponemal test non-indicated, no laboratory evidence of syphilis infection, etc. So we'll see one page, again, of all the different combinations that you possibly could see when you're testing using the non-traditional or when you're using a reverse algorithm. So those should be available later this summer. APHL, when they're available, I'm sure we'll put them in their newsletter. They'll probably send them out, certainly to the public health sector. If any individuals want to get a copy of these or want to know more about it, you can certainly contact me. You have my contact information with the presentation, or you can contact Ann Gaynor at APHL and just say, hey, when these are available, would you let me know? And I'm sure they'd be glad to refer you to the site that you could download a copy or provide a copy for you. So you can ask me, and I'll put you on a list too when they're available. Or again, Ann Gaynor. Ann's the liaison at APHL with the STD subcommittee, and has done a lot of work to keep the committee on track and to produce these documents. So there's going to be some nice resources that are going to be available very shortly for laboratories to use. So in conclusion, the guidelines from CDC would be helpful to the laboratories. It'd be really nice to get some guidelines from CDC. In the meantime, the proceedings from the syphilis expert consultation are available to aid the clinical and public health laboratories on the APHL website. APHL will make a document available for laboratories on the suggested reporting language for syphilis diagnostic testing algorithms later this summer. And more studies are actually needed to try and answer some of the questions that didn't get answered at the work group. And some of those questions are, do we have a need? Is there a need for a gold standard? Possibly a Western blot or a pseudo blot, a REBA, something like that. Do we need it? Do we need something like that to differentiate between one positive treponema test and a negative test, or two positives and a non-treponema test? Some kind of a reference referee standard of some sort. Is that necessary? There's a need for a serum bank of well-characterized sera differentiated by clinical stage for research. APHL is actually in the process of putting together a serum bank for its members right now. There's a need for a comprehensive study to compare the treponemal and the non-treponemal assays currently FDA cleared in the U.S. using sera from all stages of syphilis. And the role of the point-of-care test in the syphilis algorithm and screening. It's a treponemal test. Is there a role for the point-of-care test? And the point-of-care tests that may be coming out, what would be their role? So a lot of unanswered questions, a lot of questions and research still to come. So at this point, I'd like to end the presentation, and if there's any questions, I'll be glad to try and answer them. Thank you, and have a good day.
Thank you, Dr. Steece, for that informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. And we'll try to answer as many questions as we can. And before we get started on the questions, I just want to relay the results of our poll. So thank you so much to everybody who responded. And so the laboratory poll question was, if your laboratory currently performs syphilis testing, which algorithm do you run? The traditional algorithm, such as screening with a non-treponemal test, RPR, VDRL, and confirming with a non-treponemal test, such as EIA or CLIA, and 48% of the respondents answered to that. Or does your laboratory run the reverse algorithm, and 24% of respondents chose that answer, or 27% of respondents chose non-applicable. So thank you so much to everybody who participated in the poll. And now we will move on to our first question. So, Dr. Steece, after blood collection, what is the maximum recommended time to add on this test if it's missed at the time of when the test is requested?
Okay, not exactly sure, and so we'll take a stab at this here. I think the question you're asking, if a blood specimen comes in and they didn't request syphilis, how long do you have before you can use that specimen and test it for syphilis? If that's not the question, you'll get back to me, but that's the way I interpret this. Remember, when you're sending in a specimen, you're sending in a blood specimen, and for syphilis serology, the specimen is very stable. So there's really not like some of our other direct antigen tests where we've got 6 hours, 12 hours, 24 hours that we have to take and test it so the sample's not good. Serums, should be good at the laboratory that you submitted it to, as long as it's been stored properly for probably as long as they're going to keep it. Most of your private labs don't keep specimens very long, and the public health lab, may keep it around for, depending on what it was sent in for. So, your serum specimen is going to be stable, and, we can pull these out, for a lot of our retrospective studies, do our serology. So, there's not really generally an issue with the stability of that specimen. So you still have time if for some reason you wanted to order a syphilis test on that specimen that came in.
Okay, great, thank you. And our next question, who is the manufacturer, or who are some potential manufacturers working on non-treponemal or point-of-care treponemal tests in the U.S. that you're aware of?
Well, the manufacturer that's working on it that I'm aware of, there may be several others, but actually ChemBio. They have a nice little product, and they're, if you know anybody ChemBio, you might want to talk to them and see where they're at with that, and see if they, can talk them into submitting it to FDA and trying to get this into FDA and get it through clearance. It, it looks like a pretty good little assay, and the early performance on it looks very good. So hopefully they'll get it into FDA before too long, and it may be available.
Excellent. And our next question, so looking at, so which seroconversion occurs first, that from RPR or from a treponema-specific syphilis IgM test that you're aware of, or have studies maybe not been done to address that yet?
That's up until fairly recently, we've had syphilis IgM tests available for a long period of time. Most of the syphilis tests that we used a few years ago were not FDA cleared or approved, and some of them didn't really work too well. So I don't think we really do have a good answer to that question of what syphilis IgM test, whether that comes up before the RPR or not. I don't know the answer to that question anyway. So we do need more work, and certainly in that area. Good question.
Excellent. And recapping on what role you expect, if any, that molecular testing could play in the diagnosis of syphilis?
Okay, and again, a very good question. And as I mentioned during the presentation, I think it'd be really great to have a molecular test to directly detect syphilis from unknown chancres and or sores that potentially could be chancres, that could be confused with chancres. And CSF, as we mentioned, cases of congenital syphilis, with dark field essentially no longer available. And I think it'd be a real asset to our public health efforts to control syphilis by having this kind of a point-of-care test, if you will. We have an FDA-cleared molecular test for influenza. So the next step certainly could be a nice test for syphilis. So I hope the manufacturers are all listening, and I hope somebody's very actively pursuing that. I think we really need that.
Let's see here. Following up on, well, I guess that about concludes our time for today. Dr. Steece, were there any other closing remarks that you might have had?
No, other than, there's still some questions here. I'll take a look at the questions, and if there's contact information, or if you want to include contact information if you didn't, I'll be glad to answer those personally. So thank you very much for the opportunity, and I hope everybody has a good day.
Okay. So thank you. I just want to thank you again so much to Dia Soren for making today's educational webcast possible. And this webcast will be available for on-demand viewing through 6 months from today, or until December 25th, 2015. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. And we invite you to forward this announcement to your colleagues who may have missed today's live event. So see you next time, and thank you so much.